يلا قبل ما يبلشوا، مساء الخير دكتور باسم. أنا ما شفت دكتور باسم.
استنى دكتور فادي، كيف الحال؟
يعطيك العافية. الحمد لله الحمد لله.
ما بنسمع دكتور سامي.
So, good afternoon. On behalf of Dr. Farahat, President of CRG, and myself as Secretary General of Arab Medical Association Against Cancer, it's our pleasure to have you all with us in our ABC Oncology educational courses. And the course of today will be about GI malignancies. Just to present our panelists, whom are going to present our speakers and then discuss after the lectures. We have Dr. Zainab Benbrahim. Dr. Zainab Benbrahim, she is Associate Professor, Medical Oncology at Hassan II University Hospital, Faculty of Medicine and Pharmacy of Fez, Morocco. And Dr. Nesreen Shreet, Professor of Medical Oncology at Salah Azayez National Cancer Institute in Tunisia, and Dr. Basim Farhat, who is Consultant of Medical Oncology at National Oncology Center in Oman. Please note that our activity is translated into English and French, so you can hear it in which language you prefer. Please, Dr. Zainab, the floor is yours.
Dr.
Thank you
Sam,
very much.
sorry, Doctora, but and you have to say that it's also ASCO and UICC supported.
Yeah.
Thank you.
And awarded by 2 CMEs.
Yeah, thank you very much. First of all, I would like to thank Dr. Fadi Farhat and Dr. Sami Al-Khatib for the invitation in this ABC course, GI module. And it's clear that during 2021, we have new therapeutic strategies and treatment considerations that are expanding paradigms in GI cancers, especially in esophageal and gastric cancer. And I have all the pleasure to introduce Dr. Mustafa Tehfi. Dr. Mustafa Tehfi is a hemato-oncologist at the Centre Hospitalier de l'Université de Montréal, au Canada. He is an eminent expert in GI cancers, and I learned recently that he will have oral presentation in the ESMO next week. So without any further delay, I would like to give the floor to Dr. Tehfi to do his talk about immunotherapy for locally advanced and early stage esophageal and gastric cancers.
Thank you, Shukran, Dr. Benbrahim, for this kind introduction. It's a real honor for me to be with you today, even virtually, to share and discuss with you what's new with the immunotherapy treatment for the upper GI. And I'll share my screen. I have to switch. You're seeing, oops, you're seeing my screen You're seeing all the slides. You already know what I'm going to talk about.
Yes, perfectly. Yeah.
Okay. So I'll try within the next 20 minutes to review with you all the positive trials for the management for early and locally advanced stage of esophageal, gastroesophageal junction, and gastric cancer with the immunotherapy. And I'll be more than happy to have your question concerning any other trials, especially the negative ones. These are my disclosures, but the big disclosure is I have a lot of friends among the panelists and among the attendees, and thank you again for inviting me. You are already, you know already the gastric cancer subtype classification. There are 4 subtypes of gastric cancer. The chromosome instability subtype and the gastric subtype, but I want you to pay attention to these 2 subtypes, the EBV group and the MSI, because these 2 groups are specifically sensitive to immunotherapy treatment, whether alone or combined with chemotherapy. EBV, will see later that these type of tumors are known to be overexpressing PD-L1 and PD-L2. MSI, as you well know, these diseases are very sensitive to immune checkpoint inhibitors. This is also a reminder what chemotherapy showed for the treatment of first-line gastroesophageal and gastric cancer before the trastuzumab era. Whether you use doublet or triplet chemotherapy, unfortunately, the overall survival was below 12 months. And then for the HER2 positive and for the high HER2 positive 3+ FISH or 3+ immunohistochemistry or positive FISH, the median survival is around 16 months. And this was the first time we saw an improvement of the survival beyond 12 months for this aggressive metastatic disease. This is what I mentioned earlier. There is an important correlation between the EBV positive tumor, the MSI high, and the PD-L1 CPS score. As you see here, that patients who tumors who are EBV positive are in around 44% CPS 10 and more. In 49%, they have a CPS between 1 and 9, and 7% they have a CPS below 1. MSI high tumors, they are in 2/3 of cases, they have in 2/3 of cases overexpressing CPS with a 10 and more. But if you look for the EBV negative and the microsatellite stable diseases, only 2% of them may have a CPS 10+ score. And this is overall what we see. Around 30% of these tumors are high expressing PD-L1 with a high CPS, or between 1 and 9 or below 1. And this is why we're doing in my center for every metastatic gastric cancer, we're asking for MSI for sure, for any GI, but we're asking also for EBV, and we're testing EBV in every metastatic gastric cancer because of the high probability to be CPS high and to be treated with immune checkpoint inhibitors. Why this is important? Because you all know this phase 1 trial showing that MSI high and EBV positive tumors are the good responders to pembrolizumab. And there is no response in MSS or EBV negative tumors. So during the remaining 15 minutes, I'm going to review with you these important studies. All of these are positive studies and may lead to, or already led to, a change in our practice. The early stage, for the early stage disease, the Checkmate 577, and for more advanced stages, for the esophageal cancer, the Keynote 590 and the Checkmate 648, and for the GE junction and gastric adenocarcinoma, these for adenocarcinoma mainly, Checkmate 649. Starting with the Checkmate 577, you know very well the design. This trial was presented last year at ESMO and published already in New England Journal of Medicine. So for the stage 2 and 3 esophageal cancer and GE junction cancer, whether adenocarcinoma or squamous, but the great majority of the patients had squamous cell carcinoma. Patients were treated with a neoadjuvant chemoradiation therapy, like in CROSS trial, and there was no flood regimen given to these patients. And then the patient went into surgery. After surgery, if the patient, they have a remaining disease, whether it is a T1 or N1, and with a good performance status, patients were randomized in 2-1. For the standard arm, which is the placebo as a maintenance for 1 year, or the experimental arm, the nivolumab, 240 milligram every 2 weeks for 16 weeks, then every month with a doubling dose. And the primary objective of the trial was the disease-free survival. The treatment duration was up to 1 year. And the trial was positive. You all aware about the results. So the disease-free survival was doubled with the nivolumab as an adjuvant after chemorad and surgery, and the hazard ratio 0.69, so 31% less risk of progression of the disease with a highly significant p-value. And if you look to the results according to the histologic subtype, so squamous cell carcinoma showed the best median disease-free survival, 19.4. Then the adenocarcinoma, for the squamous, it was 29.7. The adenocarcinoma, 19.4 in the nivolumab arm compared to the same histology in the placebo arm. And if you look for the subgroup analysis for the PD-L1 CPS, and they took 5 as a threshold, patients with CPS 5 and more showed a better benefit and a better decrease in the risk of relapse or death related to the disease. So the conclusion was nivolumab was the first trial, the first adjuvant therapy to provide statistically and clinically meaningful results in improving the disease-free survival after chemorad with the surgery for the for the esophageal cancer, and this was regardless of the tumor location, histology, and the PD-L1. The more benefit we see was for patients with CPS more than 5, and adjuvant nivolumab is now considered a new standard of care. We don't have yet the OS results. These results are awaited. I'm not aware if there will be any update during the upcoming ESMO. Going to the more advanced stages. So I start with esophageal cancer, and the first study was the Keynote 590, which was presented also at ESMO and published a few months ago in Lancet. So in this trial, patients with adenocarcinoma or squamous cell carcinoma of the esophagus, locally advanced, unresectable, or metastatic, good performance status, treatment naive, were randomized between the standard arm, chemotherapy, 5-FU, and platinum-based, or the same chemotherapy backbone with the pembrolizumab, the regimen, 200 milligram every 3 weeks, up to 35 cycles, 2 years. And the dual primary endpoints were the overall survival and the PFS. So the trial was positive also. And here we have the results for every subgroup, and this was stratified initially. So for the squamous cell carcinoma of the esophagus with a PD-L1 high, CPS score more than 10, we saw an important improvement in the OS in favor of the experimental arm, so the association of chemo and immuno with a hazard ratio of 0.57, very significant p-value, and we see that there is a net separation of the curves from the beginning. When we looked for the results for the squamous cell carcinoma, regardless of the CPS, we saw also a benefit in favor of the combination immunochemo with a hazard ratio 0.72 and it's very significant p-value, and a 12-month rate survival, a 24-month rate survival in favor of the experimental arm. For other subgroups, PD-L1 CPS more than 10, regardless of the histology, whether it's a squamous or adenocarcinoma, same story, improvement in favor of the chemoimmuno arm with a hazard ratio of 0.62. And when we look for the results of all the patients, squamous adenocarcinoma, CPS high, CPS low, the hazard ratio was less important, 0.73, but still significantly statistically significant, and an early separation of the curves. Which is interesting if you look for this subgroup analysis, and you have it in the supplementary of the paper published in Lancet. If you see this, what we have seen on the curves for the squamous cell carcinoma CPS more than 10, the hazard ratio was 0.57 in favor of the combination arm. If you look for adenocarcinoma more than 10, the hazard ratio was 0.83 in favor of the combination arm, but the interval is going beyond 1. For the squamous with a low CPS, almost no difference between the two arms, the combination and the chemo. And for the adenocarcinoma with a CPS low, the hazard ratio is 0.66, also with an interval limit going beyond 1. It's difficult to comment on these results. These are two small subgroups concerning the adenocarcinoma, but still there are a lot of questions saying what we do for an adenocarcinoma. Do we have to give immunochemo for every patient, regardless of the histology, or just give it to the squamous with and the patient with high CPS? We're not doing in my center yet the CPS on the esophagus and the gastric cancer, because the tests have to be validated, but they are coming within the upcoming months. If you look for another interesting subgroup analysis, it's the Asian versus non-Asian, and here you see a net and clear benefit in favor of the Asian patient with the combination arm, which is less important for non-Asian patients. Moving to another trial for the esophageal cancer, which is the Checkmate 648. And the Checkmate 648 was presented this year at ASCO, unresected, advanced, recurrent, or metastatic, but only for squamous carcinoma, no adenocarcinoma in this trial. Again, very good performance status patients, treatment naive with metastatic and measurable disease. 3 arms, 1-1-1 at the randomization, the standard arm, which is the chemo 5FU platinum, and 2 experimental arms, nivolumab with the chemo, the same backbone, or nivo ipi without chemotherapy. The primary endpoints, dual primary endpoints, OS and PFS in patients with PD-L1 more than 1%. The trial was positive, no full publication yet. We saw the results presented at ASCO. The primary endpoint, if you look for the nivo chemo, median overall survival 15.4, the chemo 9.1, hazard ratio 0.54, and there is an early separation of the curves. When we look for the results concerning all the randomized patients, regardless of the PD-L1, we still see a smaller difference, but statistically significant in favor of the combination arm. I remind you that all the patients were patients with squamous carcinoma. If we look for the other subgroup, the nivo ipi experimental arm versus the chemo, the standard arm, here we have an improved median survival in favor of nivo ipi for the PD-L1 more than 1%. And we have also this improvement for all the randomized patients with a hazard ratio more important in favor of the patients who have a PD-L1 more than 1%. What we see here on the curve that there is an early drop of the survival in the Ipi-Nivo arm, comparing it to the chemotherapy arm in both groups. But then the benefit is more seen at least after 3 to 6 months, and the benefit is maintained all over the follow-up. I'm now going to my last trial, but here we're discussing gastric and GE junction adenocarcinoma, no squamous. This trial was presented at plenary session last year at ESMO. I had the honor and the chance to be one of the PIs and the co-author of the study, and we published it in Lancet in last June. We're doing an update of the trial in 2 weeks. In 2 weeks on September 19, concerning the third arm Nivo-Ipi. So in this trial, it's quite a bit the same design as the Checkmate 648. So patient previously untreated and resectable, advanced disease, measurable disease, good performance status, no known HER2 positive status, treatment naive. The patient were randomized between the Xelox and Folfox, not platinum 5FU, not the cisplatinum 5FU, but Xelox or Folfox. And the experimental arms, so Nivo with the chemo or Nivo-Ipi. Nivo-Ipi was unfortunately stopped early after the disease started because of the toxicity. And if you notice, the ipilimumab here in this trial was 3 milligram per kilo and not 1 milligram as we usually see in other diseases and other treatments and in Checkmate 648. And this may explain in part the toxicity we saw. I'm not going to discuss this arm. We'll see the results after 2 weeks. But I'm going to discuss what we saw and what have been published. So the dual primary endpoints were the overall survival and the PFS for these two arms. So the trial was positive when we look for the stratified and defined from the beginning, the CPS more than 5, PDL1 more than 5. The primary endpoint was the OS, and we saw an early and net separation of the curves with improvement of the median overall survival in favor of the Nivo chemo versus chemo, 14.4 versus 11. And this is the first time we see an improvement in overall survival in metastatic gastric and gastroesophageal beyond 11 or 12 months. Beside the HER2 positive treated with chemotrastuzumab. A hazard ratio 0.71, so 29% less mortality and very significant p-value. If you look for the results for the CPS more than 1, saying that it was a benefit in favor of the immunochemo combination arm with 0.77 of hazard ratio. And for all the randomized patients, we saw a benefit, which is it seems less important than we saw for the high CPS, but it is clearly there. And this was not presented at ESMO, but it is in the supplementary materials in the publication. If you look for the benefit, the most important benefit coming from the chemo-immuno combination is for the CPS more than 5. So on my conclusion, and I'll be on time, this is what these positive phase 3 trials showed that for esophageal cancer, we saw an improvement of the overall survival. If you do believe in Keynote 590, Pembro chemo is a new standard, mainly in squamous and CPS more than 10. Nivo chemo for squamous, according to the Checkmate 648. And if you don't want or you don't like chemotherapy and you're okay with the combined immunotherapy regimen, Nivo-Ipi is also an option as by the Checkmate 648. For the adenocarcinoma, according to what we saw with the Checkmate 649, Nivo chemo is the new standard. The main positive results were seen with the CPS 5 and more. And stay tuned. On September 19th, we're going to see the results for the Nivo EP. Thank you very much.
Thank you very much, Dr. Mustafa. Now it is my pleasure to introduce
Dr. Bassem. I think that Dr. Mustafa is going to his clinic. So if there is any question to him, please let us take it.
Okay.
Can I ask a question?
Yes.
Thank you, Dr. Mustafa. It was really nice and very well and very clear. Why did you choose, since you are one of the co-authors, why did you choose the EP 3 milligram? What was the rationale, knowing that nowadays we are using lesser dose?
It's an important and very interesting question. Thank you, Dr. Farhat. To be honest, when the trial was designed few years before we start seeing the toxicity, the high toxicity combining EP3 with Nivo. So this is why the initial dosing was EP3. It was designed before we learned from melanoma mainly that this combination at this dose was toxic. This is why when they designed the Checkmate 648, they change it and they choose the EP1 instead of 3. By the way, I'm not going to tell you about the results. Please assist and stay tuned for the presentation. But at least for my patient, I have to are in complete clinical and radiological remission now 3 years after treatment. Both of them received Epinivo, and both of them stopped the treatment 2-3 cycles after because of the toxicity. But they are the 2 patients who are in complete clinical and radiological remission after 3 years of treatment.
So if you allow, I just a comment. I'm sorry, Dr. Ben Brahim, I am taking, je prends la parole, it's okay. Just to say that it's again repeating the result in the renal cell carcinoma where Nivo EP patients who stopped the treatment because of the toxicity had better outcome, better long-term outcome. So it's confirming the same results.
If you survive your toxicity, you may survive your cancer, but ethically, maybe it's not acceptable.
Can I ask a question? Hassan Ghazal here.
Dr. Ben Brahim.
Yeah, okay. So I had a question for you, Dr.
Go ahead.
Actually, you showed the drop of the Nivo EP curve, even for patients with the CPS 1 and more in the Checkmate 648. So do you think other biomarkers should be explored? I don't know if there are any data about TMB in these tumors.
I didn't show the slide to respect the time allowed to me, but TMB seems more important for esophageal than for gastric. I can send you a slide. We have a nice slide showing that there are more tumoral mutational burden in esophageal and mainly in squamous when we compare them to adenocarcinoma and to gastric. And this is why, this is another explication why squamous seems more sensitive, j'aurais dû répondre en français, seems more sensitive to immunotherapy, whether alone or combined.
There's 2 questions from the audience, please, Dr. Ben Brahim.
Okay. So one question, it is for unintended patients with metastatic squamous esophageal cancer who underwent palliative local chemoradiotherapy to the primary. What is your choice as palliative chemotherapy, and this for unknown PD-L1 status?
If your patient is eligible for systemic treatment, ECOG 0 and 1, and you have access to pembrolizumab, I would give pembrolizumab with chemotherapy. The problem and the question we're discussing with my colleagues every time, the trial was done with cisplatin 5-FU, but at least in my center, we're not using any more cisplatin 5-FU. We're using FOLFOX for squamous and for adenocarcinoma. We don't have enough evidence to say that even if we know and we do believe that FOLFOX is giving the same result as cisplatin 5-FU, but do we have to extrapolate? I don't know. In my center, my pharmacist won't allow, because here everything is controlled by our pharmacists. By the way, they are very nice. I don't know in your centers if you can extrapolate, but I would recommend pembro with chemotherapy, 5-FU and platinum-based if your patient is eligible, he has a good performance status and no contraindication to the platinum. If not, FOLFIRI as a first line is also an option.
Okay, second question, is there any clinical implication for EBV testing in gastric cancer?
There are no clinical trials showing that EBV patients, comparing EBV patients' treatments, immuno versus no immuno, but there are a lot of trials and showing that EBV positive gastric cancers are a high expressor of PD-L1. So this is why we're testing EBV. We're not giving the EBV positive immunotherapy as a first line because of the lack of the evidence, but EBV patients are given immunotherapy in second and third or beyond if are still eligible for treatment. We are recommending doing EBV, yes, when we do MSI testing on our gastric cancer, metastatic, and GE junction.
Okay, so I think that two attendees are raising their hands. Dr. Mohammed.
Yes, hello, good evening.
Yeah, good evening.
Yeah, thank you, Dr. Mustafa, for the presentation. I'm Dr. Mohammed Sir. I'm an oncologist from NCCR. I have a question, actually. We know from the Checkmate 577 that we have a role for nivolumab following chemoradiotherapy for SCC, esophageal residual disease. I have a question about a particular patient of mine. This patient was treated with definitive chemoradiotherapy for a mid-thoracic tumor, and later on he had recurrence. We had to resect it, and unfortunately it was an R1 resection. So in the MDT, we discussed giving.
I'm not hearing your question.
Yeah, Dr. Sir, we lost you. Dr. Mohammed?
Yes, can you hear me now?
Yes.
Yes.
Okay, I have.
In MDT. You were saying in MDT you discussed, and then after we lost you.
Yeah, okay. In the MDT, we discussed giving him a session of radiotherapy for the residual disease, for the R1. Will there be a role for nivolumab for 1 year in this patient?
There is no evidence because it is a recurrent, and we didn't do the surgery. So by the keynote 577, the answer is no. Beside this evidence as a medical oncologist, it depends if you do believe that your patient still have micrometastatic disease and nivolumab would help, and you have access. Personally, I'm not against, I would do the same thing. The other option is I may test the patient for the MSI, for the EBV. Is he adenocarcinoma, I guess? It's
No, this patient was a squamous cell carcinoma, and actually he did the surgery. The surgery was R1. But
okay.
The surgery was done on a recurrence, not like the original Checkmate 577.
And your radiation therapy was done after the surgery?
Yeah, so he took a definitive chemoradiotherapy. He was followed for a while. He had a recurrence.
So the surgery
we had a surgery again. Yeah, so this was the salvage surgery, exactly. And it was an R1 surgery.
Those patients were not included in the trial, but I personally do believe that nivolumab may help, yes.
Yes, yes, exactly. Thank you very much.
Dr. Hassan Ghazal was trying to ask some question, but I'm not sure if he's still online with us or not.
So I
Yes,
suggest
hello.
that,
Just one quick question. It's more about, first of all, thank you for very comprehensive talks. The question I have kind of partially answered in terms of juggling between Pembro and Nivo, and would you keep each indication separate, and the type and the partner chemotherapy, what would you think of the partner in each of the two? And then what do you think of the FDA approval in the US, where everybody was surprised? This is the first time FDA is more liberal than NCCN, knowingly that the proportion of patients with low PD-L1, especially with the Pembro, that had to go to 10% to get this the significant difference. But my understanding also in the FDA panel problem was the type of testing that was used for PD-L1 was kind of confusing to them. That's why they were more liberal to just give an indication for all comers. What do you think the bottom line on that? Because that's the most confusing part now to us as clinicians.
Thank you for your question. You already answered a part for concerning the testing. It's really difficult, and now it's the real discussion concerning how we compare the two antibodies, the Merck one and the BMS one. It's hard to extrapolate from one trial to another. In my center, we didn't already started to do the PD-L1, although we are the biggest center in Quebec, because they choose to go for the Roche antibody, and they want to validate it. Hard to tell because we're not using the same antibodies. Concerning the and this is maybe the answer. This is why the FDA, they approved for every patient, and they didn't specify depending on the CPS level. I do believe, at least for me, for the CPS high patient, here we saw the most important benefit. I can't deny the immunochemo for any other patients, but they have to be aware. We discuss all these details with the patients. So we discuss with them the smaller benefit when they have a low PD-L1 or CPS, and the risk of toxicity by comparing it to the chemotherapy. I don't know if I did answer your question. Concerning the other part for the chemotherapy, we use FOLFOX for the when we combine, when we treat adenocarcinoma, and this is why we're doing Nivo FOLFOX for GE junction and for gastric and for adenocarcinoma of the esophagus. But for the squamous, we have Nivo and Pembro, but in both trials, as we saw, the chemotherapy backbone was cisplatin 5-FU. So for the moment, we're using cisplatin 5-FU and not FOLFOX. And if we want to use FOLFOX because the patient has a contraindication to cisplatinum, we discuss it to our pharmaco committee in the hospital. We have a pharmaco committee, mainly oncologists, oncology pharmacists. They are all aware of all these data, and we have to convince them if we want to change the chemotherapy from cisplatin 5-FU to FOLFOX, and to show them prove that the patient has a clear contraindication to cisplatinum. Otherwise, I would go for Pembro with cisplatin 5-FU and Nivo with FOLFOX.
In the same context, we have one question in the audience: if there are any tolerance issues with Nivo FOLFOX?
No, I treated more than 20 patients with the Nivo FOLFOX in the trial, and we didn't see any strange toxicity by giving this combination. We have the same toxicity we all know and we all experienced with the chemo or the immunotherapy alone. But the combination of the Nivo IPI with the IPI 3 mg was really toxic.
Dr. Mustafa, since the release of the data, I had personally 2 patients receiving FOLFOX/nivo, also very good tolerance and nice result till now. So I think it's really good tolerance compared to the platinum-based treatment.
With FOLFOX, right?
Yes, sure, as per protocol.
And they have an excellent doctor, ومحب كمان.
It's
So,
biased.
for the time, I'm asking, thank you, Dr. Mustafa. So I'm
Shukran.
asking Dr. Bassem to proceed presenting our next speaker.
Shukran.
Our next presenter is our colleague's friend, Dr. Muhammad Abdullah. He is a professor of clinical oncology at Al-Qasr Al-Aini Medical School, Cairo University. He will talk to us today about the sequential treatment of the unresectable hepatocellular carcinoma. We welcome Dr. Muhammad.
Thank you too much, Dr. Bassem, and I admire the kind invitation of our friend, Professor Fadi Farahat, and I'm honored really to be with you today in this event for the first time. I really admire the kind invitation. My topic will be rather a hard one. Can you show me my screen? I am actually sharing my screen.
Doctor, we are not seeing the screen. Can you please try to share it again?
Share it again. Okay. Okay, it's seen?
Yes.
Okay. I know that all of my friends here in the panel, we started our career as in the medical oncology and in the clinical oncology a long time ago. And I do believe that, or remember, that when I started my career about 32 years ago, when I find a patient with HCC, I had nothing to offer except for pain relief or something like that, as no treatment was considered to be associated with satisfactory results for the patient. So it's a hard and tough topic, not only to offer the patient a treatment, but to go further and trying to discuss what are the available lines, the sequential treatment for patients with advanced or unresectable HCC. Here by my disclosures, firstly, I have to remind you all that we have in between the problems with patients with HCC. Usually we have cirrhosis of whatever etiology. It could be viral, it could be metabolic, or due to alcohol consumption in over 85% of patients. And usually this is coupled with 2 events: the organ dysfunction of variable grades and the presence of advanced HCC. Both definitely are quite fatal. When we think about the systemic treatment offered over the past 2 decades, usually we achieve modest survival gain, and definitely we are going to face a lot of complications that will add to the patient's symptomatology. So we have to respect the crosstalk between the organ dysfunction, the HCC state, upon selecting the proper treatment, especially that we don't have really a unified algorithm to predict the function and survival upon treating patients with HCC. 2007 was considered as the golden year. Since then, this was the year where sorafenib was approved as a first-line treatment for patients with advanced HCC upon the release of the data from the SHARP trials. 10 years elapsed, and we had a flood of agents. Most of them were TKIs, tackling the HCC as an angiogenic tumor. 2017, we started to have 2 new good news. We started to consider the second-line treatment following the release of regorafenib following the failure on sorafenib in the RECOURSE trial, in the resource trial, and we started to think immunologically. We had the data for the nivolumab from the Checkmate 040. So the timeline of the approvals is quite condensed. How to choose? We learned that sorafenib is an accepted first-line treatment for patients with advanced HCC, and it was coupled with velindvantinib, being non-inferior to sorafenib even with a more favorable adverse event profile. And for the second-line treatment, we had a lot of agents, most of them TKIs, going to tackle the disease, and they were randomized against the best supportive care. So all of them nearly had associated with improvement of the survival outcome, whether we consider regorafenib, cabozantinib, ramucirumab, especially in patients with alpha-fetoprotein level above 400 nanogram per milliliter and so on. And we started to push for a second-line treatment. But we should not forget that the incidence of grade 3 or more adverse events with sorafenib or the TKI's treatment is not that easy to neglect. We have for sorafenib, definitely we all know that we are going to face fatigue, diarrhea, abdominal pain, hand and foot syndrome, and ascites. All of them definitely are going to add to the patient misery. While for lenvatinib, being also used in the first-line treatment of advanced HCC, hypertension comes on top. The weight loss increased the blood bilirubin, reflecting some deterioration of the liver functions in addition to the patient hematology. But by time we started to care much about the adverse events encountered with the TKI treatment, as we are going to offer our patients nutritional support, trying to control the hypertension in a better way, trying to use something topical for the hand and the foot syndrome, so as to make life somewhat pleasant to the patient with HCC going to receive the TKI. This was reflected definitely that when we consider the first period of the treatment with sorafenib in 2008 to 2012, when we find that the majority of our patients can be withdrawn due to treatment discontinuation, either due to progression, liver failure, also intolerance. It was about 21% of patients could be withdrawn due to the adverse events encountered on sorafenib use. But step by step, our learning curve is improving. And when we consider the period between 2013 to 17, it was dropped to 9.4%, only 9.4%. This subset was added to the patients going to continue treatment and supposed to have some benefit, and this was statistically significant, as you see, 0.001. What's the impact of better treatment of the adverse events? It was translated into a survival advantage. When we consider the period 1, the median overall survival was about 8.9 months, increased to 14.3 months beyond the year 2013. And the duration of treatment was about to be doubled. This was confirmed in many of the literatures thereafter. And they added other endpoints like the rate of disease control, which was significantly improved also, duration of the treatment, and the dose intensity for patients going to receive the treatment. Upon this, we considered best candidates for sorafenib as a first-line treatment, in addition to the disease parameters like the alpha-fetoprotein to be lower than 400 nanograms per milliliter, those with dermatological adverse events supposed to have somewhat improvement in the outcome. The period of treatment was definitely increased, but focusing on the patient himself. Those with child A disease score 5 points. This is the most common group to show a benefit, in addition to those with performance status adequate, 0 versus 1, and those definitely without macrovascular invasion. Then, since 2017, we started to move into the immunogenic era, and although I have some concerns about the liver being an immune-tolerant organ, so the value of adding monotherapy of immunotherapeutics available did not offer much to the patients over the TKI. Then we moved to the combination therapy, and I think our practice today is controlled via the MBRAVE 150 study using atezolizumab plus bevacizumab versus sorafenib, and definitely we have significant improvement of the overall survival and progression-free survival with really an amazing hazard ratio of 0.58 and 0.59. But don't forget that nothing is without expenses. Don't forget the immune-related events, especially the hepatitis, that could add to your patient's misery. And don't forget the complications of the anti-angiogenic therapies, especially the bevacizumab. As you know, most of our patients are cirrhotics, so you do expect to have portal hypertension and the event of esophageal varices. So you have to look carefully for your patient. Is he having really esophageal varices or not, so as to be treated or ligated before the start of such event, although we have a question mark on this. But anyway, we had something added to the survival outcome of our patients. So the first line now, you can go for either sorafenib, lenvatinib, and lately the immunotherapy plus atezolizumab plus bevacizumab. But our learning curve with sorafenib being older in the market, who is the best candidate treated with sorafenib therapy to consider for more and more intensification or prolongation of your treatment duration? And we had some data coming from the resource trial following failure on sorafenib with disease progression. The use of regorafenib, another TKI, it was associated with significant improvement of 3 months with the median overall survival approaching 10 months, particularly when we have a patient still with child score 5 or child classification A, good performance status, no macrovascular invasion, and still having good range of his hepatorenal profiles. So the second line, or offering a patient subsequent to treatment to expose your patient to more treatment lines with the TKI, this was associated with survival improvement over time, overall survival improvement. So we could have now a therapeutic platform for advanced HCC. If you are seeking for the survival outcome and your patient is not that much symptomatic, go ahead to atezolizumab plus bevacizumab, then to be followed by other lines available as a second line, like the regorafenib, Bramo, or cabozantinib. Still, you have the pleasure to go for the original sorafenib or lenvatinib. But for patients, when you are seeking for rapid response rate, and this data coming from the last ASCO GI in the beginning of this year in January, when you have a patient, you are seeking for rapid response rate with improvement of the overall survival, definitely you have to seek for the lenvatinib, and then upon progression, you can go for the second line. For the second line, they have elected cabozantinib because it was associated with significant improvement of the progression-free survival when compared in meta-analysis to the other agents used. So, start moving from no treatment except best supportive care to the era of TKI as a first and the emergent second line data, to the era of immunotherapy and the combination immunotherapy with anti-angiogenic agents. We are moving ahead, and definitely we are achieving better survival outcome for patients with advanced HCC. But please don't forget that you are treating really an exhausted liver. You have to focus on the function of the liver so as to predict which patient can withstand your treatment. I can summarize the art of today that the survival in advanced HCC undoubtedly improved with the introduction of molecular targeted agents, sorafenib, with better experience in the management of the adverse events. Sequential therapy combining multiple drugs has improved the survival in patients with advanced HCC through adding further lines of the treatment, although we don't have yet data for the third and fourth lines. And when performing a multi-drug sequential therapy, it's important to start your treatment when the patient shows a good disease condition, namely through his laboratory assessment, and to find what you have or what you have really in your patients regarding his general condition and in relation to organ function. Also, we learned that we have to avoid overuse of TACE. Why? Because it will exhaust much of the liver, and you have to stop before losing the way to give systemic treatment for your patients that could achieve better survival outcome. I think I have stuck to my time. Thank you for your attention, and I welcome your questions.
Shukran, Dr. Thank you very much. Now the floor is open for any questions.
I raised my hand. Can I ask a question?
Yes, sure, my friend.
Dr. Muhammad, it was really fantastic. Thank you very much. I want to ask you about the TACE. How can you lower the use of TACE? You are right, when we had nothing to offer, and in the era of sorafenib, we had nothing also except sorafenib. So we used to, we overused TACE. But at which moment you will stop your TACE and start doing something else, I mean, medical treatment? It's somehow tricky because the indication is clear here.
Yes, yes. I think we have to go back to the clear indications of TACE and not to overuse it, because we do expect to have definite loss of significant portion of the liver reserve. And your patient is going to show deterioration and is going to die because of the liver failure rather than the disease. Let me tell you that, you know, in Egypt, we have a high incidence of HCV infection, although we had the campaign to control such infection now, and we started to see a reflection of this vaccination and the treatment. But on the other hand, most of my patients, or the patients I have seen over a very long time, they did not really die because of their tumors. They died because what we have did from tackling the liver directly through unnecessary liver interventions. I think TACE, I can repeat it 2 times, 3 times on the best hand. This is definitely depending on the disease extent and the involvement of the liver parenchyma. But more than this, and if you don't have really impressive control of the primary tumor with TACE, you should not go more than this, particularly if the lesion is involving more than 20% or 30% of the liver, or scattered in both lobes or something like that. I think here we have to be realistic, stop and go to the systemic treatment, as it's not going to hurt the liver directly. It's not going to kill the liver directly, particularly in the presence of positive macrovascular invasion. You are going to kill the liver. So after the first or second time of TACE, we have to stop and discuss the case through the MDT. How can we offer this patient better lifestyle, better control of his disease? we can control the disease, yes, but you are going also to kill the patient through induction of the liver failure. So to my mind, it's just 1 to 2 times, and then you have to stop and strictly assess your patients.
Thank you.
I have one question.
Sure.
Yeah, thank you. Dr. Mohammed Abdullah, you showed the great outcome of new combination atezo-beva. And according to the ESMO MCBS scale, it is ranked in the top of the scoring system. So let me ask you a provocative question. Is there any subset of the HCC population for whom you would not treat with this combination in first-line treatment?
Okay. Usually I don't offer my patient an active treatment, whether immune or TKI, except if he is really in a good performance status, 0, not even 0 to 1 hardly, and I am concerned much with the liver function. As you have seen in my slides, that usually in treating patients with HCC, you have an intertwined dilemma. Is your patient going to deteriorate because of the liver functions, or due to the cirrhosis, I mean, or due to the tumor itself? And I think we have today, in today's practice, we have nothing called monotherapy through using the immunotherapy, because the liver is immune tolerant organ and the patient is going to get any more benefit than the TKI. But in our region, and as you know, the availability or the access of the drug is not that sufficient for all the population. Our health resources cannot support this. So if I have the pleasure to go for immunotherapy, I have to be sure that this patient is not having, for example, esophageal varices, or not having a state or impending hepatitis element, which is difficult to find the patient really among my population without esophageal varices or impending hepatitis at any time that can lead to loss of the patient himself. Still, we might have some shift to the TKI in the majority of our patients, first because of the economic burden, but we have some data now, as I have told you, from the ASCO GI in the beginning of this year, that through the meta-analysis published, that if you are going to treat a patient without symptoms, but he has advanced disease, mandating systemic treatment, this is a place for atezo-beva based on the survival advantage achieved. But when your patient, for example, is metastatic, and this is quite evident within my practice here, if I have a patient with pain, with bone mets, with due to the disease, lenvatinib really is a good choice. And it can control the patient's symptoms in short duration. Don't forget that you are still talking about a patient terminally ill, and you should not waste time trying to seek for the survival advantage and not focusing on the patient's symptomatology and the possible anticipated liver failure. Most of my patients with HCC were lost because of liver failure rather than disease progression.
Thank you.
Dr. Hassan Ghazal.
Am I clear
Yes.
on what I said?
Yeah, thank you very much.
Yes, so thank you for this interesting comprehensive talk again. My question, I guess, may coincide with the previous question, but so obviously the atezo-bevacizumab is for patients who are fit patients. We have to understand that, and at risk of bleeding. The other point I want to mention, in the patient who have underlying NASH, non-hepatitis, the data actually was not impressive at all. So we need to be careful, I think, in choosing, like you said, exactly right, who to give atezo-bev to. And the other question I had, like you mentioned lenvatinib, and it was one of our, standard of care in first line, probably still for some patients. It has pretty strong anti-VEGF activity as evidenced by the rate of hypertension, etc. So do you know, I know there were few hemorrhages with the lenvatinib, but they weren't as pronounced as when we used bevacizumab. So can you comment on that safety measure, or should we really worry about all these patients, even when we're giving single agent TKI, about bleeding tendency? Especially this is one of the strongest anti-VEGF agent. And as a branch question, we know lenvatinib plus pembro data is coming, and if this turn out to be safer in a way, the data, than the bev atezo, do you think that may take over as well for safety reason, if efficacy is comparable?
Really, Dr. Hassan, I admire your three questions. I think they are to the target. For the immunotherapy anti-angiogenic agent with HCC, let me ask a question. You know, in Egypt, HCV is a big problem, and most of our patients are cirrhotic due to the HCV. They lived long time, and suddenly we discover something in the liver that I do believe it was there for many years and undiscovered. Now we are discovering much cases because we are seeking for treatment and treating for HCV. So we found more and more patients because I'm not complaining. Why to go for ultrasound and doing something like that? Okay, but if I am positive, I have to be included within the screening program because now it's officially mandatory in Egypt. But if I don't know that I have a disease, so why to do investigation? Time will pass and the disease will progress, but still your patient is not symptomatic due to the malignant disease. This is part. He is symptomatic because of the compromised liver function. This should be taken into consideration while deciding to go for an active treatment. Because the patient usually is going to come to me, and I found him good candidate to receive first line atezobeva by radiology, by laboratory. He has no esophageal varices, and everything is fine. But he is going to ask me a question. Am I going to be cured? The answer is definitely no. Can I go back to my lifestyle and activity, go to pray in the early morning, to go to my work, to have good lifestyle with my family? Again, the answer will be no, to be honest, because it will not improve what we have due to the damage of the cirrhotic patients. This point was raised by me in many of the advisory reports and in the meeting. I need to specify that patients with viral hepatitis inducing cirrhosis, could they really benefit from such combined treatment? Yes, they are going to do so. But how many the percent of patients with active viral hepatitis within the IMbrave 150? Actually, for the sorafenib itself, when we go to the initial SHARP trial, the number of HCV positive patients, they were just 29%. It's just justifying the use of sorafenib among our patients. To answer your questions, we need to have trials in our region because I do believe that our patients are something different from the pathogenesis, from the disease behavior, from other points. But definitely we don't have the pleasure to have this. We will not be allowed to do this. But I have to follow the guidelines until we have the ability to develop our own guidelines. When I went back to the biology of the disease, the pathogenesis of the disease, Roche started to fight me, I'm sorry to say so, because I found that liver is really an immune tolerant organ. There is exhausted T cell activity. So you have soldiers or you have weapons without real soldiers to fight your disease. And this was maybe the philosophy of combining something with the immunotherapeutics like the vascular endothelial growth factor inhibitor like beva, and started to maximize the benefit of using such agent immunologically through the inhibition of the vascular endothelial growth factor A and its ability to re-stimulate the natural killer T cell and recruit a lot of things, as you know. So again, back to your question, so as not to be away. I think we have to be quite smart when we decide to go for such expensive agents together, even if they showed the maximum therapeutic response. But when you go to the metabolic syndromes, where it was the majority of the patients in the EMBRAVE 150, definitely there is deregulation of the immune system at this point. But in our patients, it's the problem of what we call the necroinflammation. It's the process of necroinflammation, which is peculiar to the viral hepatitis, which is another story. So make your mind, select your patient according to what we have in the literature, in the trials. Try to discuss all the adverse events that can be encountered. Try to focus on the viruses and the liver profile, and try not to lose your patient, not because of the disease, but because of the liver failure.
No, absolutely. And I think it's just to confirm, they already tested, for example, nivolumab as single agent versus sorafenib. It wasn't enough. It was not enough. Right. And back to your point of NK cells and the actual immune cells, that's why there's ongoing trial with the triplets now, or doublets. We know the tremi, durva, tremi. There is one epi-nivo plus cabo, actually, cabozantinib. So we will know more, but if the problem is tolerance, absolutely. The triplets are going to be rough to take.
Yes, but the Himalaya trial, when we talk about the Ctl4 inhibitor, I think this is another story than the other PD-L1 inhibitors. Because as you know, the problem in the liver itself. You get something from outside, like T cells that are going to be maturated in the thymus and try to tackle the liver. It could be another story on the basic research or the basic data or basic knowledge. But I think we have to wait a lot to verify and ensure the safety of treatment with such intensive approaches to our patients in the region.
Thank you very much. Thank you very much, Dr. Mohammed Abdallah. I think that we should move to the next session. Dr. Khatib.
Yeah, please. The discussion was really excellent, and we have a lot of questions in the Q&A box, but we don't have a lot of time, so we are going to the next session, colorectal cancer session. So our panelist is also...
Excuse me, I'm going to leave because I am actually in my clinic and I have to leave.
Dr. Muhammad, thank you for the time that you give us, and always you are excellent collaborator with us.
It's my pleasure, dear Dr. Sami.
Thank you, thank you, Dr. Muhammad. So our panelist for the second session, Dr. Zainab bin Brahim also, which I presented, Dr. Fadia Ilyas, she is hematologist oncologist at Mount Lebanon Hospital in Lebanon, and Dr. Hassan Ghazal, consultant medical oncology and clinical hematology, King's College Hospital in Dubai. So the floor is yours to present our next speakers, and please start.
Okay, thank you very much. So I have the great pleasure to present, to introduce my friend, Dr. Al-Mehdi Tazi. to present a talk about primary tumor resection plus chemotherapy versus chemotherapy alone for colorectal patients with asymptomatic synchronous unresectable metastasis. And Dr. Mehdi Tazi graduated from the National Institute of Oncology from Morocco. Now he is practicing in the private sector at Ibn Sina Cancer Center in Qnitra. Dr. Tazi is also member of the board of the Moroccan Association of Oncology of the liberal sector. Without any further delay, I give the floor to you, Dr. Tazi.
Merci. Donc, je vais faire ma présentation donc en langue française, comme ça a été convenu avec mon... Vous m'entendez?
Oui, parfaitement.
D'accord. Donc, comme ça a été convenu avec Dr. Farhat. Et donc, je suis...
Excuse-moi, Mehdi. Just, I would like to remind that this presentation is translated into English. So Dr. Tazi will do his presentation in French. Thank you very much.
Merci.
Vas-y, Mehdi.
Voilà, d'accord. Donc, je remercie vivement le docteur Fadi Farhat et le docteur Sami Khatib qui m'ont permis donc, de siéger parmi vous aujourd'hui. Et donc, c'est avec un grand plaisir que je vais présenter un sujet un petit peu controversé qui est celui de la chirurgie de la tumeur primitive dans le cancer colorectal métastatique, mais définitivement non résécable. Donc, comme vous le savez, je vais passer vite, c'est un problème de santé publique avec une incidence en forte augmentation du cancer colorectal. C'est également dans notre pays, le Maroc, la deuxième cause de décès par cancer de l'appareil digestif. Et puis, il y a une nette amélioration de la prise en charge par les réunions de concertation pluridisciplinaire, par le développement de la chirurgie et par un meilleur accès à un arsenal thérapeutique qui est de plus en plus étoffé. Donc, qu'en est-il de la résection du primitif d'un cancer colorectal qui est d'emblée métastatique et qui est non résécable? Donc, ça veut dire qu'il faut tout simplement prioriser les choses et avoir la possibilité de traiter à la fois le primitif, mais également les métastases. Donc, ce sont deux axes de réflexion différents. On prend en charge le primitif quand on est obligé de le prendre quand il y a une urgence, par exemple une occlusion, une perforation, ou bien lorsque le malade il est très symptomatique, anémique, besoin d'être transfusé à chaque fois, infecté, très algique. Donc, le but de cette chirurgie du primitif, c'est de dégager un bénéfice de la résection systématique du primitif et bien sûr la prise en charge de métastases va se faire donc en parallèle. Donc là, on s'adresse à un groupe particulier de patients, c'est-à-dire un groupe qui est incurable et qu'on va opérer le primitif sans opérer automatiquement les métastases. Donc, le but de cette intervention, ça reste une meilleure survie avec une meilleure qualité de vie. Bien sûr, là, je vais vous énumérer donc, certains avantages de la chirurgie, notamment la levée de l'obstruction, le contrôle de l'hémorragie, etc. Mais il faut savoir que cette chirurgie programmée va augmenter la mortalité, comme on va le voir, qu'elle est quand même assez morbide et qu'elle peut également induire un retard de mise en route du traitement. Quelles sont les critiques des gens qui opéraient d'emblée ce genre de patients? Parce qu'on n'avait pas donc suffisamment d'études, notamment il n'y avait que des études non randomisées jusqu'à celle du GCOG 1007. Donc là, on va revenir à notre étude. Donc l'étude de GCOG 1007 est une étude japonaise multicentrique qui s'est étalée de 2012 à 2019 et qui a randomisé des patients à une chimiothérapie plus une thérapie ciblée, c'était du folfox6 modifié ou du capox avec du bevacizumab, ou bien une chirurgie programmée du primitif suivie de chimiothérapie. L'objectif principal était la survie globale. On voit les caractéristiques des patients, ce sont deux bras qui étaient bien équilibrés, notamment pour la localisation, la taille tumorale et l'atteinte métastatique hépatique. Et là, les résultats ne sont pas très bons, comme on le voit. Sur la courbe A, donc il n'y avait pas de différence en matière de survie globale en médiane de survie. C'était la première analyse intérimaire en septembre 2019, suivie d'une deuxième analyse. Donc, c'est un update qui a été fait en novembre 2019. Donc, on voit qu'il n'y a pas de bénéfice à opérer le primitif. C'est même un petit peu délétère. Quand on regarde la courbe de survie sans progression, on voit tout simplement que c'est des malades qui vont progresser beaucoup plus que ceux qui ont reçu de la chimiothérapie seule. Et on pourrait dire que cette chirurgie programmée serait même délétère. En analyse en sous-groupe, on ne trouve aucun groupe qui bénéficie de la chirurgie du primitif. Elle est même vraiment très délétère pour les patients qui sont en mauvais état général. Donc avec des ECOG PS A1 ou plus. En ce qui concerne la mortalité, pour le bras chirurgie, les patients, un patient sur 5 avait une toxicité, morbidité grade 3 à 4 et il y avait 3 décès en post-opératoire, ce qui n'est pas négligeable sur à peu près 81 patients. La toxicité était majorée dans le bras expérimental, notamment donc, le bras résection primitive plus chimiothérapie. Ce sont les toxicités surtout non hématologiques. Là, on va reprendre rapidement la conclusion des auteurs. C'est une étude qui est bien sûr négative sur son objectif principal et les voire délétères pour le bras expérimental. Les limites de l'étude restent bien sûr statistiques sur la taille de l'échantillon et la puissance de l'étude. Un défaut de recrutement, absence d'études de qualité de vie et bien sûr non-inclusion des tumeurs rectales. Et il y avait même des inclusions de patients qui étaient subocclusifs dans le bras standard. Donc, qu'en est-il de la vraie vie et des données qu'on a de la littérature? Il faut savoir que ce genre de patients qui sont non résécables sur leur métastase vivent entre 20 et 30 mois. Donc, c'est un groupe assez particulier. Pourquoi, bien sûr, les opérer? Là, pendant notre première année d'internat en oncologie, on nous sortait la théorie de Goldie-Coldman, c'est-à-dire que si on arrive à diminuer la masse tumorale, on va améliorer la réponse au traitement et diminuer ce qu'on appelle des clones résistants. Mais en même temps, il faut savoir qu'en 2021, on a un arsenal thérapeutique qui est quand même assez étoffé et qu'on peut proposer plein de choses à nos patients. Là, c'est l'évolution donc de la survie globale pour le cancer du côlon métastatique, pas toujours opérable. On atteint 21 mois avec de la chimiothérapie conventionnelle, 30 mois avec les biothérapies, sinon plus chez la population MSI avec l'étude de Checkmate. Là, j'ai essayé un petit peu de compiler ce qu'il y avait dans la littérature. Donc, dans la littérature, il y avait plusieurs études. On va dire c'est des études qui étaient non randomisées, souvent monocentriques et rétrospectives, avec un bénéfice important en survie dans la majorité des études. Là, je reprends la dernière qui est celle, donc pas la dernière, mais celle de Mehdi Karoui de l'hôpital européen Georges Pompidou. C'était une étude qui était positive sur 208 patients, mais qui n'ont pas reçu de biothérapie. Le premier signal négatif donc est apparu dès 2012 sur donc une revue et une revue de la littérature de la Cochrane Database qui reprenait donc des patients qui ont été opérés de leur primitif alors que les métastases n'étaient pas résécables et là, il n'y avait pas de bénéfice. Donc, après 2012, on a eu plein d'autres méta-analyses, d'autres études qui donnaient des signaux positifs, notamment celle de Similis avec l'équipe de M. Cunningham. Donc, il y avait également donc, un bénéfice dans cette méta-analyse, certes limité en survie globale, mais ce qui nous intéresse ici, ce sont la morbidité. C'était une morbidité qui était excessive pour les patients qui ont été opérés et avec un retard de prise en charge médicale. Là, on reprend les données du CIR qui ont été présentées par une équipe chinoise. Entre 2004 et 2013, quand même, 26 000 patients qui étaient non résécables sur leur métastase ont été opérés de leur primitif. Et là, on voit qu'il y a un bénéfice net en survie globale et en survie spécifique du cancer pour les patients qui ont eu une résection palliative. Donc, on monte un petit peu dans les niveaux de preuve. Et là, c'est une phase 2 randomisée coréenne dont l'objectif primaire était la survie globale à 2 ans. Donc, il n'y avait pas beaucoup de patients. Il y avait à peu près 26 patients dans le bras expérimental et 22 patients dans le bras standard. Il y avait donc un bénéfice sur la survie spécifique au cancer qui n'était pas l'objectif primaire, mais plutôt l'objectif secondaire. L'objectif primaire n'a pas été atteint et donc il n'y avait pas de bénéfice en survie globale à 2 ans. Et on s'est retrouvé avec un taux de complications à peu près de 20% de morbidité post-opératoire. Qu'en est-il du rectum qui a été exclu de l'étude donc JCOG 1007, malheureusement, donc, ce sont des patients qui n'ont pas été inclus dans l'étude. Là, c'est également donc, une étude chinoise qui a repris les données du CIR. Et là, on voit qu'il y a un bénéfice très, très important. Certes, qu'il n'y a pas beaucoup de patients qui ont été opérés. C'était 494 sur une durée de 5 ans. Et il y avait un bénéfice, comme vous le voyez sur les courbes, qui était spectaculaire en survie globale à 5 ans. Donc, on est passé de 5 à 27%. Donc, ça envoie un petit peu un pavé dans la mare. Mais bon, maintenant, je pense qu'on a plein de traitements, que ce soit de la chimiothérapie, la radiothérapie ou bien l'association des deux pour pouvoir donc contrôler la tumeur rectale. Qu'en est-il des biothérapies et notamment l'utilisation du bevacizumab? Donc, on a une étude monocentrique coréenne donc, qui s'est étalée sur 12 ans et qui a pris en considération donc, des patients qui ont été opérés puis soumis à une chimiothérapie plus BEVA, des patients qui ont été opérés durant la chimiothérapie, on n'a pas dit pourquoi, probablement pour des complications, et des patients qui ont eu une chimiothérapie seule BEVA. Donc là, c'est sans appel, la chirurgie du primitif améliorée de manière très, très importante. Donc, la médiane de survie de ces patients. Et souvent, donc, c'est une décision qui est difficile. Est-ce qu'on opère, on n'opère pas? Je pense qu'il y a certains facteurs pronostiques qu'il faut prendre en considération, à part l'étude JCOG 1007, qui reste une phase 3 avec un niveau de preuve qui est quand même assez suffisant et qui a démontré la limite de la chirurgie du primitif. En ce qui concerne les facteurs pronostiques qui ont été dégagés en analyse multivariée, des patients avec une atteinte du parenchyme hépatique supérieure à 50%, qui ont beaucoup de métapéritonéal pulmonaire, avec un âge quand même assez avancé, mauvais PS, ne doivent pas être proposés pour une chirurgie du primitif. Par contre, malheureusement, dans la littérature, on n'a pas beaucoup d'analyses géniques, notamment la mutation du BRAF. Est-ce que ce sont des patients qui doivent être opérés ou bien à l'ère de la trithérapie plus du bevacizumab, il ne faut pas toucher à leur primitif? Comment, moi, je me suis intéressé pourquoi ces résultats un petit peu disparates et pourquoi il y avait tant de résultats qui étaient positifs. Donc, j'ai trouvé donc le papier du maître Robert Weinberg, un autre papier sur l'inflammation systémique, et ça disait un petit peu que quand on enlève la tumeur, donc on a moins de sécrétion de cytokines et de facteurs de croissance tumoraux, et qu'on a moins de production de peptides résistants, et ça permet tout simplement de retarder le phénomène de progression tumorale. Et il y a également la diminution des complications qui sont liées à la tumeur primitive, mais ceci, il est à contrebalancer avec le taux de complications sous chimiothérapie seule. Donc, le taux de complications, il est de 10%. Donc, on n'a pas tellement de complications liées à l'utilisation du traitement médical seul sur la tumeur primitive, et que les anti-angiogéniques n'augmentent pas les complications en cas de tumeur en place. On sait très, très bien maintenant qu'on utilise des anti-angiogéniques avec une tumeur en place, avec pas de morbidité ajoutée. Quelles sont les pistes à venir? Ben, on va attendre donc d'autres phases 3. Une autre phase 3 qui est coréenne, donc un petit peu chez une population asiatique similaire qui est en cours, mais on attend surtout l'étude Cairo 4 qui est une étude néerlandaise sur la population caucasienne et l'étude allemande Synchronos qui a été designée pour répondre et voir est-ce que on va retrouver les mêmes résultats ou bien on va retrouver des résultats disparates chez la population caucasienne. Donc, en guise de conclusion, donc ça reste un sujet controversé avec des résultats contradictoires, que le premier essai randomisé prospectif, il est franchement négatif. On a un mythe qui s'effrite sur le primitif. C'est comme dans le sein, on a vu une étude turque qui était positive, après toutes les études étaient négatives. Donc, on attend un petit peu la confirmation avec les autres études, l'étude coréenne, allemande et néerlandaise. Et puis, si jamais on est dans une équipe qui préconise la chirurgie du primitif, ben, il faut sélectionner les patients en RCP, sélectionner des patients asymptomatiques, assez jeunes, moins de 70 ans, avec un excellent PS et pas beaucoup de métastases hépatiques. Donc, je vous remercie. S'il y a des questions, je suis là pour y répondre.
Merci, Dr. Tazi. So let's take questions for this lecture. I think that Dr. Tazi, so he concluded that maybe we have controversies concerning the surgery of primary in synchronous metastatic unresectable colon cancer, and maybe it would be the best option only for patients who are asymptomatic, young, with a good performance status and with less than 50% of liver extension. So my question, Dr. Tazi, what is the best timing of surgery for these patients? Is it before or at best response of systemic treatment?
Donc, pour moi, sincèrement, il n'y a pas de bon timing pour la chirurgie. C'est-à-dire que quand le patient il est vraiment asymptomatique, c'est-à-dire qu'on n'est pas obligé de l'opérer pour son primitif pour lui régler un problème, c'est-à-dire un problème de perforation, d'occlusion, de douleur, de problèmes infectieux, je pense qu'il ne faut pas opérer les patients, sincèrement. Donc, avec ce qu'on a comme arsenal thérapeutique, donc je pense qu'on a assez de médicaments pour gérer médicalement un cancer du côlon qui est asymptomatique. Sinon, ce qui a été designé dans les études, c'était une chirurgie programmée, c'est-à-dire au moment où on fait le diagnostic, on suppose que ce sont des patients qui sont asymptomatiques de leur tumeur primitive, on les opère, on attend qu'ils récupèrent, puis on démarre leur chimiothérapie, plus ou moins une biothérapie. Et là, quand on les opère, quand même, on a un patient sur 5 qui a des morbidités très importantes, qui a des pertes de poids, des altérations de l'état général, et on peut retarder de manière très importante la mise en œuvre d'un traitement médical. Moi, je ne suis pas sincèrement pour la chirurgie du primitif de manière systématique.
Merci.
So can I have a comment? Hassan here, Ghazal.
Yeah.
So I think in my mind, I agree totally, Ustaz. I think in my mind, the main reason I would go ahead and resect a primary, if this is a potentially resectable liver metastasis, that's different than you are treating for cure. Or there is obstruction, obviously, or bleeding complication before you start therapy. The problem is we have also data that if you start with surgery for just because you want to remove the primary, and the patient, let's say, have lung and liver mets where it's not candidate for any curative surgery, you may actually, by delaying his chemotherapy, we have seen cases where, let's say you have a complication and the patient surgery complicated by whatever, and the patient is not ready for chemotherapy, it could be for 4 to 6 to 8 weeks sometimes. And during that period of time, we have seen cancer progress so quickly. So there is absolutely no reason to remove a primary unless the indications I just went through, and that's what I think Dr. Taz went through. And it's actually, sometimes we see surgeons seeing these patients before us, and they have already done the surgery, and then they refer to you, oh, okay, they have metastatic disease. And that's really the worst scenario. That's why it's very critical to present these cases in MTDs with the surgeons, with medical oncologists, to make the best decision for each patient on a case-by-case basis.
Yeah, I totally agree with you, Dr. Hassan. Even in our MTD in Morocco, we go rarely for surgery for these patients. Do you agree, Mehdi?
Oui, je suis tout à fait d'accord. C'est-à-dire que déjà, il faut bien sélectionner les patients. C'est-à-dire que ce sont des patients qui sont définitivement non résécables, c'est-à-dire pas potentiellement résécables. Dans les études, c'est vrai qu'il y a des patients qui ont eu donc une résection du primitif, une réponse spectaculaire au traitement. Après, on a pu donc les réséquer. Mais là, c'est un groupe bien particulier, c'est-à-dire que c'est des patients qu'on n'arrivera jamais à les opérer de toutes leurs métastases. Et donc, pour moi, c'est une perte de temps si on les opère alors qu'ils sont totalement asymptomatiques. Et je suis content que l'étude JCOG 1007 a été négative. On va attendre avec impatience l'étude Cairo 4 et l'étude Synchronous pour voir est-ce que les populations caucasiennes donc, ne bénéficient pas de la chirurgie du primitif comme la population japonaise. Et je suis d'accord avec le docteur Razel.
Merci beaucoup.
If I can make a last comment, I think that the aim of this presentation was achieved. Really, it's an educational activity. The aim was to raise awareness about this procedure, and we know very well that I hope that after such presentation, doctors will think longer and will try to consult in MDT or other to make the decision. Thank you very much, Dr. Tazi. I gave you a hard task, but you did it.
So shall we move to the next talk? So I have the picture. Yeah, go ahead. Excuse me.
Good evening. I'm Dr. Fadia Elias. I'm going to present Dr. Farhad. He's going to talk about metastatic colorectal cancer treatment. But before, I want to say that, as you know, colorectal cancer treatment has evolved. We started with chemotherapy, then we have target therapy, we have anti-VEGF, anti-EGFR, anti-BRAF, we have checkpoint inhibitors, PD-1, PD-L1 inhibitors, Ctl4 inhibitors. And then, as you know, we choose treatment according to criteria, according to guidelines, NCCN or other guidelines. Every single patient with colorectal cancer, even in early stage, should be tested. RAS, BRAF, and MSI should be done. So without any further ado, I would like to introduce Dr. Farhad. Dr. Farhad is well known by all of us. He's head president of CG, and head of hematology oncology department at Hamoud Hospital. And he's going to talk about target therapy in metastatic colorectal cancer with sequence. Dr. Farhad.
Thank you very much. Yeah, merci. Thank you very much. So we are 30 minutes late, but it was very nice till now. I hope we'll continue. Targeted therapy in metastatic colorectal cancer. which sequence. Metastatic colorectal cancer, it's really now a huge disease. I mean, it's not only one disease. So this is supported by Amgen. I am responsible of all what will be presented during the slides. So I start by showing this presentation. You all know now we talk about receptors, about ligands, about pathways, and we also talk about the treatment with the anti-receptors or anti-tyrosine kinase inhibitors, or about the treatment on the downstream pathways in form of inhibitors. And we are now talking about a combination in some cases. So it's very important to talk about that, because we will have later on anti-MAC, now we have anti-RAS, anti-EGFR, anti-VEGF, just to understand why we should see this picture. And here I would like to show you that the exposure to many agents made possible the improvement of survivals. We started with the classical 5-FU leucovorin, then after we increased the treatment by using the bolus 5-FU, then after irinotecan, then after oxaliplatin, plus infusional 5-FU, etc. And when biologics arrived, we observed really a very nice improvement, and we surpassed the 2 years, and now we arrived up to 34 months overall survival in some cases. And as you can see, presented in another way, you can see that different protocols improving. The improvement is not only due to the introduction of new medication, it's probably also related to the better management. And now, what can make the difference in survival between different patients? So many factors. There is some tumor characteristic, which is the environment, the presentation. There's some anatomical factors like the rectal or left colon, the left versus right colon. There is the molecular and immunological characteristics like the KRAS and RAS, BRAF, HER2, the MSSS, and other. So these are really the tumor characteristic. What about the patient characteristic that can play a role? We know very well now that comorbidities, performance status, age, organ function, all of these may have an impact, such as the others, on the overall survival and on the outcome of the disease. Also, the treatment characteristics may play an important role, and it's usually neglected in some other cases, but we have to insist that the socioeconomic factors and the quality of life, the access to drug availability, all these will play a role. And we have to say also that the patient preference and the patient expectation are important. And you know very well that we used to say that for some patients, for example, rash is unaccepted. That's why we used to avoid EGFR inhibitors and so on. So how this will impact our patient? If you look on the patient characteristic, you will find that, for example, for ESMO guidelines, we start by deciding which patient is fit, unfit, or maybe suitable for the treatment. So the patient characteristic will play really an important role in the decision to treat or not. And if we want to treat, is it chemotherapy, simple combo of 2 drugs, or it's more? And if it's unfit, if the patient is not doing well, we will not give treatment. So yes, patient characteristics are important, as you can see. Also, we will talk about the tumor characteristic. What about the tumor characteristic? It's when we the tumor characteristic when we say that the disease is resectable as metastatic, or if we are talking about simply cytoreduction or simply disease control. So the ESMO divided these patients to different groups, as you can see. Clearly resectable metastasis, or maybe resectable or that need to be shrinked, or simply disease control. And here also the treatment will be different. We'll not go through that. But also the tumor characteristic are the profile of the cells. Is it, we have to go for the RAS, RAF, and now we have the ANTRAC, the HER2 and others. We have to study the specificity of the disease. So I go back to the title, which sequence targeted therapy in metastatic colorectal cancer. It's important here to talk about the first-line therapy, to know if there's any importance of the first-line therapy selection. Is it really important, or we can start with any other treatment? You know that in other diseases, we might say we can have different protocols. We can start with anyone, like for example, a breast cancer. You can start xelodanavir, or you can start taxane with anthracycline, or you can start simply with monotherapy. So is it really different in metastatic colorectal cancer? What's the importance of the first-line therapy? Also, what's the importance of molecular testing? And I think it's important in all type of cancers. The tumor sideness, is the right breast different than the left breast? You will never ask such question. You will never dare to ask this question, neither for the lung, for example, knowing that the lung are anatomically different, but apparently in the colon, it's different. So the tumor sideness, is it important or not? And finally, we will go to the question, the main question of the topic, which target and which sequence. So I will start by asking the question, how many will receive the first line? This by itself will give an importance to the choice of first line therapy, knowing that all the patients almostly will receive chemotherapy in first line. This make things, this push us to think really hard, since the second line, a lot less, much less patient will receive the treatment. As per the file trial, it was 70%. Median for all the trials is 53, and the third line is 28. So yes, if I choose the best treatment in the first line, probably I will help these patients, since they might not have the chance for the second line. But is the effect of this treatment, is the effect of the treatment in first line having an impact on outcome? We will see that yes, probably since the first line response is higher in the, the response for treatment is high in the first line, as you can see here, less than the second and the third, as it is in the majority also of the tumors. The PFS also is better. So yes, probably it's important. So here the question will be, so if the first line treatment is giving a higher outcome, can we say that there is a relation between the response rate and the PFS on OS? So are the outcome of the first line impacting the overall survival? The answer will be that probably it seems that there is a connection between the response rate and the overall survival in frontline therapy, because when there is a tumor shrinkage, in other terms, the depth of the response will improve the survival. And here, the classical graph that you know, and you can see that the partial response with 30% response is not the same as a deep response, 90% response of the tumor. We knew that, but as you know, the 30% or 40% response rate is put in the same category of the 90%. It's simply partial response. But we know very well in our practice that there is a difference. And we know that since the tumor will relapse, as you can see in green, when it relapses with a deeper response, probably there will be a difference in overall survival. And yes, it seems that there is a correlation between the depth of response and the overall survival. For example, in the FIRE3 trial, we can see that there was a deeper response with a better targeted therapy, and this was correlated with overall survival. You know, the FIRE3 showed an overall survival benefit as secondary endpoint, but without reaching the primary endpoint. But nevertheless, we can see that getting a deeper response probably will impact the overall survival, as it's shown in this slide. You can see green, it's BEV, and le gris, the remedy, it's the cetuximab, and we can see that there is a difference between the cetuximab and bevacizumab, and the delta is high. So we know that now that there's a need to choose a good first-line therapy, since it's impacting our survival. We'll go to the second point, the importance of initial molecular testing, and the guidelines now are clear. You can see that you have to test always for RAS and for RAF as per NCCN or per ESMO. And in my opinion, not only these tests. And remember that the wild type KRAS represent almost 50%, a little more. And remember also that we have a switch of 10% from wild type to metastatic. And also, please remember that the use of RAS will help our patient. Will help our patient when giving the EGFR inhibitors, will increase the result. And look here, the RAS wild type population, when there is no mutation, the hazard ratio is 31% for the OS. It means we are decreasing the deaths by 31%. So here, just to show the importance of the RAS testing, if you test the RAS and your patient is wild type, the induction with the anti-EGFR treatment will lead to an improvement in overall survival by almost 30%. And as you can see here, the response rate in different trial, PRIME, Crystal, and others, is showing an incremental response of 30% to 27%, while with bevacizumab, it's not the same. So yes, choosing the treatment based on the molecular testing is improving the outcomes, the overall survival, and the response rate. This was about the RAS, and if we take the different head-to-head trial, we can also say that you can observe really the difference. The overall survival is in favor of the yellow, which is the anti-EGFR. So anti-EGFR versus anti-VEGF in RAS wild type. It shows the importance of this molecular testing, the same for PIC trial and the same for the CLGB, comparing also the cetuximab to the bevacizumab. So the idea here is to show that testing, the molecular testing will lead to an improvement in result when you choose the adequate treatment. And here I will not go through the trial again, but the meta-analysis showed also an overall survival and PFS benefit when you use this treatment. Now we will go to another mutation with the BRAF, and here the BRAF has also, even if it's rare, but it has a prognostic impact. As you can see, when we have a BRAF mutation, the survival is worse. And we know that if you use an anti-BRAF treatment, we can reach a better outcome, as you can see on the orange curve. So again, molecular testing for the RAS and now for the BRAF is prognostic, and what's most important is predictive. You remember at a time we had the debate, should we test the BRAF or not, and why to test the BRAF, since we will say to, what can we say to the patients, you have a bad disease, so some of us will not taste it at all at this time. But when we started having an anti-BRAF treatment, we started testing, and not only started testing, we now know that it's an obligation to test this BRAF mutation, to search for BRAF mutation, because otherwise, if you don't give the adequate treatment, the result is bad. And here, just I want to remind you that, remember, some of targeted therapy like aflibercept, not only anti-BRAF and anti-MAC might be helpful, but some of treatment like aflibercept might be helpful in such cases. And also the HER2 amplification, now the HER2 is everywhere. So we know also that HER2 has is a prognosticator also, and we know very well that also with anti-HER2 treatment, you will get a better result. And we can see here how much control of the disease we have with in yellow partial response, and the I forgot how you say it. In the green, it's also good when you use the anti-HER2 treatment. So the idea that oncologists know now very well is that you have to do the molecular testing because not only to has a prognostic indication, but also to treat. And when you have a treatment anti any active alteration, you have to search for it. So now we all are aware about the NTRK fusion testing, the ALK fusion testing, and the ROS1 RET fusion. So we know very well that it might be possible to have such alterations. And we know also that we have the ATM mutation and MET amplification. Remember that different alteration will not have the same impact. In some cases, the amplification has a significant value, and we have it might impact while it might be the mutation or the fusion. So pay attention to that, please. So also the immunotherapy, and as it was very well presented in the first two presentations about the immunotherapy, we know very well that in the GI, the immunotherapy is well efficacious in esophagus, squamous or adeno, in stomach, and even in HCC with excellent results in some cases. It's also the same for the MSI colorectal cancer. So when you have a deficiency for the mismatch repair, you can use this treatment, and you can see the difference when giving a really combination treatment. Here I showed you the Pembro result. You see the difference when it's mismatch repair deficient tumor. You have an excellent result compared to non-mismatch repair or to mismatch repair proficient. And here we see also the difference when you add the immunotherapy. Really, the overall response rate is incrementally increased. So after talking about the first-line therapy selection and the molecular testing, now what about the tumor sideness? Is it really important? As I told you, there's no difference between left and right breast, neither left and right lung, simply anatomically, but functionally no difference. While here, apparently, we have two different organs, totally different organs. The right colon and the left colon, it's coming from different origin embryologically, and that's why we have two different organs, let's say. The left colon is from hindgut and the right colon from midgut. And we know that they have different even function physiologically. Both are here to absorb nutrition and water, but there is some different in the fermentation and else, while, for example, rectum is simply for fecal store. But also they have different incidence, and this is fortunate because the right colon is worse. We know that it's the third of tumors. And we know also that the presentation might be different, and this is due to the anatomy of the disease. And we know also that the right colon usually has larger tumor, vascular invasion, high TNM and high grade, etc. So it's worse as a presentation. And we know that molecularly and immunologically they are different. We have more a BRAF mutation and a RAS mutation, which the RAS we don't like at all in the right, while in the left we have more EGFR expression. So is it important to differentiate between right and left? Yes, because if we go to the early stage, like stage 3 colon, you can go from the up to up down. You start by the colon and the sigmoid colon, and you can see the median OS is really fantastic compared to the lower organ going from left to the right. The survival is different, and here it's simply it's only stage 3, which means already no impact for the targeted therapy, neither the neither monoclonal antibody, because we know very well that in the stage 3 we give simply chemotherapy. So it's very important to mention which side, and we know that again the left side colon significantly has better overall survival versus the right. And even for the treatment, if it's RAS non-mutated, in different trials we can see that the PFS is better for those who has a left, for those who have left tumor compared to the right, if they use the treatment, the monoclonal antibodies or not. So it's better to have a left colon even when we have the RAS mutation, and the same for the PEAK trial and the same for the 181 trial. And also the overall survival is different. Look, the difference between the left and the right in a blue, two blue, the left and the right for those who received the monoclonal antibody, and for the left and the right who didn't receive the monoclonal antibody. So even if you receive the monoclonal antibody, in the left side, in the right side, you do worse. So it's always good to have left tumor. And also for different trials, we can observe the same. This is for the anti-EGFR panitumumab, and even for the cetuximab, you can see the difference in curves. So just to say that you have to take in consideration the importance of the sideness, just to know about it. Okay, what about the treatment sequencing? What can we do now? We know very well that after the assessment of clinical condition of the patient, if the patient is fit to the treatment, we search for the goal. And if it's the cytoreduction or disease control, we will do the molecular analysis. And as you can see, if the RAS is mutated, there is no question. In mutated RAS, we have nothing left for us. We have only the VEGFR inhibitors to use. And so there is no discussion, no debate in such indication. And also if we have a BRAF mutation, we do not have this problem of what treatment to choose. But the problem is when we have the wild type RAS. At a time we had the discussion, should we go for anti-EGFR or anti-VEGF? And I think this debate should be finished nowadays, and it should be clear that when you give the anti-EGFR in such cases, when the RAS is mutated, the benefit is clearer when you add an anti-EGFR compared to anti-VEGF or compared to nothing, and the incremental difference is significant in different trial. Here you have the 8.1 difference in the comparison head-to-head. Here 3.5 in CLGB, it's a direct comparison, and the PEAK trial direct comparison, while the other it's anti-VEGF versus nothing. So it's evident that when you have a RAS mutation, you have to start the anti-EGFR. So you can argue also, since our patients, and you put usually the strategy when you see a new patient, you put your strategy. I will give the first line, this type of line, the second, the third. Every oncologist has this map in his head when he sees a patient for the first time. So you can argue that I might start with anti-VEGF plus chemo and then use the EGFR on the second line, which might be also a possibility. No, it was proven that if you use the anti-EGFR in second on third after a bevacizumab treatment or without bevacizumab treatment, the blue, the upper is without bevacizumab previously or with bevacizumab previously, the green, there is a difference. So if you use an anti-EGFR therapy in third line and we use it, if there is a bevacizumab in prior line, it's worse than if you haven't used bevacizumab. So this personally will push me to avoid bevacizumab in previous line. And we know that the VEGF-A is increased in patient serum when we use anti-VEGF therapy. Does it has any importance? Yes, because in vitro VEGF-A induce resistance to cetuximab in 3 colon cancer RAS wild type cell lines. So probably yes, if you use the anti-EGFR cetuximab panitumumab after bevacizumab, you will reach less result. And if you use it before, like this schema, primary anti-EGFR, you will have more reduction of tumor size. We know that the overall response rate is higher. We are talking about the RAS wild type, because in the RAS mutated, there is no debate. And we know that we have a deeper response and faster response. And we know that the sensitivity to secondary anti-VEGF therapy is higher. And this was proven also in the FIRE3 and PEAK. Will not go through all the data. And the primary anti-VEGF therapy, when it's used first, it might prolong PFS, but less effect on tumor size and plus long, less rapid treatment effects. And it decreased the sensitivity of the anti-EGFR therapy, as it was proven in the SPIRIT trial and the COMET trial. So how to proceed if you have RAS wild type colorectal tumor? You might start with an anti-EGFR with a chemo doublet, and then after you use an anti-VEGF or VEGF trap, or one of these 3, bevacizumab, aflibercept, or ramucirumab. And then after, you can go the third line to the EGFR antibody cytotoxic doublet. And then after, you choose the regorafenib or TAS-102. And for sure, we are talking about RAS wild type with no other alteration. I mean by that, no HER2, no BRAF, no MSI. And you can argue if you had an excellent response in first lines with the anti-EGFR, you can start with the anti-EGFR. I will never start without anything than the EGFR inhibitors in first line for RAS wild type. Then after you change the chemotherapy and you change your monoclonal antibody to a VEGF inhibitor if you wish. And here I am using a lot of aflibercept with very good results. And then after you move to a new line, cytotoxic doublet with anti-EGFR, and you might repeat in a fourth line the anti-VEGF. And then after you move to regorafenib and TAS. Why I'm saying that? because these last drugs, even if it's oral, it's usually toxic, and the quality of life is impaired in such treatment. Now, you might ask me that what should I do if the cytotoxic, if the EGFR is not ready when I have to start? Recently, a paper was published showing that there is no harm at all if you start the first cycle with cytotoxic doublet while waiting the molecular testing, and it was published and showing that there is no difference. And with that, I finish my presentation, and I thank you very much, and I leave the floor to you, dear panelists. Thank you.
Thank you, Dr. Farhat. Very nice presentation and very relevant. And as you said, the best treatment should be used first, of course, according to molecular testing. If anyone has any question, or I will ask you about the re-challenging with anti-EGFR in third line, of course, in RAS wild type. Do you consider a re-challenge patient with anti-EGFR? And if so, you prefer to do to retest patient before doing so? I mean, to test for RAS another time?
It depends. If the patient responded well with a prolonged progression through PFS, I re-challenge easily, but I re-challenge after modifying the treatment. It was shown, there is a very nice slide, a sketch showing that when you use the anti-EGFR treatment first line, then after you go for the second line, there is a new rising EGFR sensitive, anti-EGFR sensitive clone. So yes, when you modify your target inhibition, you might use a previously used treatment. So if I have a good response and good PFS in the first line for the anti-EGFR, I can use it in the third line without retesting. But if I had a bad response initially in the anti-EGFR, it means that there is probably some other alteration, or it means that we are missing something. In this case, I go and repeat the testing, but indeed what I try to do is a larger genomic panel in order to catch any alteration like RET or NTRK or any HER2 or anything else. So when you feel that there is no response, it's really the need, it's here the time where you need to do a genomic analysis in order to catch these rare alterations.
Okay, thank you. I have a question. For right-sided, the KRAS wild type, do you prefer first choice BEVA or anti-EGFR?
For
right-sided.
Right-sided. Indeed, it's a debate.
For right-sided, yes. KRAS wild type.
Indeed, whenever I see a KRAS wild type, I mean pan-RAS wild type tumor, I will try the VEGF inhibition, the EGFR inhibition, even if it's right-sided. But it's very rare to find a RAS, non-mutated RAS in the right side. But if you have a RAS non-mutated, RAS wild type right tumor, go for anti-EGFR. And here I will ask this question for Dr. Kakil, because he is also expert in GI. And for the audience, do you have any different opinion for that?
Yeah, Dr. Fadi, the data, they prefer the BEVA with the chemotherapy in the right side, the data supporting that better progression-free survival and overall survival. So, but unless you are looking for a response or in borderline resectable tumor in the liver, in such cases, you go for anti-EGFR. Otherwise, you have to go for anti-VEGF.
That's why I asked Dr. Kakil, because I knew that he will respond me such way. But remember that in all trials, having KRAS in right colon, KRAS non-mutated was really rare. And that's why we cannot take a conclusion. Personally, I am a supporter of the molecular decision after testing. I think even in the right colon, whatever you have as mutation, you have to follow it. So I'm now giving you the word. Do you think, did we have a big subgroup in the presentation in the right-sided colon with RAS wild type receiving?
Yeah, we with that presented in the many conferences in the ISMO and the ASCO when they subgroup analysis and the right side is different from the left side, definitely.
Yeah, I know the presentation, but I'm still using it. And I had one patient and I used the anti-EGFR and surprisingly it was giving well. So personally, I am sticking with using anti-EGFR. So maybe we can hear the opinion of Dr. Ben Brahim, Dr. Tazi.
Yeah, I would like to comment on this. Actually, I agree with Dr. Kakil that the meta-analysis showed better overall survival and the progression-free survival for left colon from EGFR inhibitors. But this picture was not seen with objective response. So we still have better objective response with EGFR inhibitors, even in right colon cancers. So in my opinion, I would treat my patients who needs conversion to resectability. I would treat them with EGFR inhibitors, even in right colon cancer.
That's what Dr. Kakil said, exactly.
Yeah, yeah.
Je suis du même avis dans la mesure où ils prennent en considération la profondeur de réponse. Et donc, la profondeur de réponse pour les surtout les méta-hépatiques, quand on doit opérer un patient, la profondeur ne change pas entre un côlon droit et un côlon gauche. Et donc, on peut le rendre résécable avec cetuximab ou panitumumab, donc par rapport à du beva, très probablement. Donc, en matière de réponse objective, je ne pense pas que ça change grand-chose. Et puis, les anti-angiogéniques marchent mieux pour les lignes ultérieures.
Okay, thank you.
That we have more evidence this year in the ASCO 2021 with the deeper study. It's compared FOLFOXIRI Bev versus FOLFOXIRI EGFR inhibitors, and here again we had the smallest benefits from EGFR inhibitors in terms of depth of response. So I still on the same association for this for patients with right colon cancer.
Can I say something?
If you allow me to start with the next speaker, because we are too late.
If just one comment, Dr. Khatib.
Please.
I respectfully disagree with the response, because in the randomized, I know the numbers look better in per trial, but in the true randomized trial, there is no significant difference. Numerically, it was better. And more than that, the one study we have was neoadjuvant in terms of trying to convert a potentially resectable tumor using an anti-EGFR. That study showed no difference really in the resectability after using anti-EGFR. So I don't think we should generalize too much. I agree that the numerically responses has been somewhat better with the RAS wild type, but really in the randomized trial, we didn't see that statistical significance between anti-EGFR or VEGF. Just to be on the other side of the wagon.
Okay, thank you. Please let us proceed with our next speaker. Who's going to present Dr. Kakil?
You, Dr. Sami.
Yeah. So I would like to introduce Dr. Kakira Rasul. He is a hemato-oncologist at the National Center of Cancer Care and Research in Qatar. He will enlighten us with the presentation about encorafenib plus cetuximab as new standard of care for previously treated BRAF mutant metastatic colorectal cancer.
Thank you.
The floor is yours.
Assalamu alaikum. Thank you, Dr. Zainab. And first, I would like to thank Dr. Fadi and Dr. Sami to inviting me for this nice, interesting, well-organized meeting. It is first time for me to be here as speaker. And also, I would like to thank them for giving me the permission to invite my colleagues from Iraq to join this webinar, which is very helpful for them from Kurdistan and from other parts of Iraq. And I saw many of them already join the webinar. By that, I will start my presentation. This is my disclosures. I present a few slides about epidemiology of colorectal cancer. And you can see it is the third common cancer after lung and breast internationally, and around 2 million. This is in 2018, 1.8. By now, it is, I think, approaching 2 million. And for the mortality, again, it is the second common after lung, and nearly 1 million people die of colon cancer. So it is a common cancer. I will go through some data from our area. This is from Qatar. We can see it is colorectal cancer, new cases in 10 years, it is 10% of cases, the second common after breast cancer. And interestingly, in our data, we see young population, and about 40% of our patients below age of 50, which is interesting, and is a high number. And this is maybe because of the population structure, but still, even in Qatari, we have a good number of patients below age of 50. The second thing, in the staging of the cases, we can see stage 3 and 4 constituting about 62% of our patients, and 38% of our patients are stage 1 and stage 2. We don't have much data from the area, from other countries about this staging, about the age of distribution of our patient. So for colorectal cancer, we need a precise medicine and precision medicine to treat our patient, and there is a heterogeneity of these patients. We have to use the molecular profiling as these markers are prognostic and predictive to our treatment, and these cases are this variable in different group of patients. And you can see from here what we have in colorectal cancer, about half of the patients are the RAS mutant when we are limited with the target of these patients. But we have the wild type, although Dr. Fadi mentioned 40%, but in our data, in our center, it is in the range of less than 30%, 28 or 30% of cases. And we have the BRAF, which is 10% of cases, the V600E and the non-V600. We have the other rare mutation, the MSI high, the HER2, the PIK3. These are also rare mutation. Our area of interest for me today is the 10% of cases, which is the BRAF V600E mutation. Although it is constituting 10% in our center, we have data from our patient. This is the range of BRAF mutation, the range of 10%, 10 to 12% of cases, and the MMR deficient cases in our data between 8 and 10% of cases, which is nearly similar to the international data. But even with the BRAF, it is 8 to 10%. If we compare it to melanoma, in which the BRAF is about 50% of cases, we have seen as cause of death, much patient die from BRAF mutant cases of colorectal cancer because we have the large number of cases of colorectal cancer cases. And the type of mutation is the predominant type is BRAF gene, which is 90% of cases when there is change of valine to glutamine at codon 600 with the activation segment result in active mutation BRAF 600E. Other type of mutation includes substitution, nonsense, deletion, and translation. These are rare, but this type of tumor not different from the RAS wild type or RAS mutant. It is completely different from the BRAF V600E. And there is some crossover between BRAF and MSI high in sporadic cases of colorectal cancer when we have overlap on about 30 to 50% of cases, sporadic cases, having BRAF mutation. And in these cases, no need to go for genetic testing for these cases. It is a somatic mutation. These are the non-V600E RAF mutation, a rare type. It is constituting 2% of colorectal cancer cases. And usually we can test for BRAF either on the tissue by the paraffin fixed specimen, or we can do it on the liquid biopsy by testing the blood for the BRAF can be tested in these cases and give you a good concordance rate. BRAF is a prognostic marker, and we can see patients with BRAF mutation, they have poorer prognosis than other cases. We can see this is the wild type, this is the mutant, and this is the BRAF mutant cases, and the different progression-free survival and overall survival, same thing, the RAS, the BRAF mutant having poor outcome when compared to other type of the mutation. And for the non-V600E compared to B, we can see this is the difference. This is the BRAF V600E. This is the non-BRAF 600E, and this is the BRAF wild type. We can see the difference how the BRAF is a bad prognostic picture. Again, even with the MSI high, MSI unstable, when we have BRAF mutation, they have worse prognosis than the BRAF wild cases. And even when they have a patient with liver metastasis, resectable liver, those patients having poorer outcome, even if you resect the tumor when compared to the RAS wild or RAS mutant cases. But this will not deny the patient who have liver metastasis, if he is BRAF a mutant, to have liver resection if it is resectable. Still, it is better than non-resecting these cases. The treatment for patient in the first line, till now we are using the chemotherapy with the target therapy, and this is the outcome. We can see the overall survival. Patient were receiving the triplet when compared to the doublet. This is the TRIBE1 trial, but this data was contradicted in the TRIBE2 when using the triplet with the target with the anti-VEGF, and it's same that it is no difference when using doublet or triplet, and this is, we're changing the guideline that you have to use doublet because very rarely patient can relate the triplet, a lot of side effect with this combination. And this is the FIRE 4.5 comparing the triplet therapy with the anti-VEGF and anti-EGFR, and the data supporting that anti-VEGF better than anti-EGFR and BRAF mutant cases in the RAS wild type. And we can see this is the outcome in the overall survival and progression-free survival. The patient with the anti-VEGF having better outcome than anti-EGFR. So chemobiotherapy for BRAF V600E mutant metastatic colorectal in the first line, doublet bevacizumab is the standard first line treatment. Triplet may be interesting for tumor shrinkage or patient with a threatening disease having symptom, and the anti-EGFR, no advantage on bevacizumab. What about the target for BRAF mutation? This is what we are talking about today, and this is the signaling pathway for the metastatic colorectal cancer. We can see the EGFR go through the RAS, BRAF, and MEK and ERK inhibition. So if we want to block this signaling pathway, which lead to proliferation of the tumor cells, we have to block. And melanoma, we know just using anti-BRAF will lead to response of this patient, but this is completely different in colorectal cancer. Using BRAF, anti-BRAF alone will not have effect in this patient. And this is the signaling pathway, because if you block the BRAF, there will be feedback, and the still signaling pathway will work in these cases, and the tumor continue proliferation. So that's why we need to have blockage more than the one pathway, using the anti-EGFR, anti-BRAF, anti-MEK to control. This is when using the BRAF blockage alone. This is done long time ago, nearly 10 years ago, when using vamurafenib, which is used in melanoma as a single agent in BRAF mutant colorectal cancer. It is not effective in these cases when compared to melanoma. So the combination of this target therapy using the anti-EGFR, anti-BRAF or BRAF inhibitor with the MEK inhibitor lead the investigator to use in this combination. The first one is the Encore Trial, which is a randomized open-label 3-arm phase 3 trial, multi-center in patient with BRAF V600E metastatic colorectal cancer after first and second line of chemotherapy, using this triplet combination or doublet combination. And these are the doses of BIMI metinib 45 milligram BID, and encorafenib 300 once daily, and cetuximab 400 to start with, then 250 weekly. And we can see the 3-arm, nearly more than 200 patients enrolled in each arm of this. And the primary endpoint is overall survival and overall response rate for the triplet versus the control. Secondary endpoint were overall survival, overall response rate for doublet versus the control and versus the triplet therapy, and also the safety profile of this combination. This is the outcome. We can see the triplet compared to the doublet. The initial analysis, we can see the median overall survival 9 months compared to 5.4, and the triplet, and 8.4 compared to 5.4, and the doublet, with the overall response rate and the triplet 26%, and with the doublet 20%, with the control only 2% of cases. Further analysis of this data, later on they found that the median overall survival 9.3 for the triplet compared to 5.9 for the doublet. It is achieving same median overall survival of 9.3 compared to 5.9. So both arms, the triplet and the doublet, they're having very similar, but in the response rate, the triplet 27%, while the doublet is only 20%, and both of these were significant difference with the control. If you using so there is complete overlap of both curves for the triplet and the doublet combination, and you can see from the curves here. Regarding the definite deterioration or quality of life with the triplet and doublet, again, there is no much difference in the outcome between the two arms. So further updating the analysis of the Encore trial, the triplet and doublet demonstrated improved overall survival and overall response rate with BRAF V600E mutation when compared to the current standard chemotherapy. The safety profile was consistent with the non-safety profile of each agent and consistent with the primary analysis of this patient. We can see the triplet in certain patient may be helpful. Patient having poor feature, like patient having more than 3 organ metastasis or patient having not resected the primary, those patients may do better when using the triplet in this patient. This is the side effect. We can see that between the doublet and triplet, the grade 3 are less side effect with the doublet than when compared to the triplet. It is expected because more than, even in addition to this clinical side effect, also there is financial toxicity for the triplet is more expensive than doublet in this patient. Updating the side effect grade 3 again, we can see with the doublet, we have less grade 3 side effect when compared with the triplet. So in conclusion, for BEACON study, combination of encorafenib with cetuximab and bimitinib resulted in significantly longer overall survival and higher response rate than the standard chemotherapy in patients with the metastatic colorectal cancer cases. Now, this, if we have some data about patients who used bevacizumab in the first line, we say the standard treatment is the triplet or the doublet with the bevacizumab. They found that patients who received bevacizumab in the first line, they have worse outcome than patients without bevacizumab, and this is clearly seen in the outcome when we can see 12 months compared to 8 months and 10 months compared to 8 months. So there is some drawback, as mentioned by Dr. Fadi, because when patients receive anti-VEGF in the first line, you know the effect of anti-VEGF, it takes 10 to 12 weeks to clear up. So in this time, usually the anti-EGFR and even anti-MEK will not work in this patient well. And we can see clearly that the patient who receive anti-VEGF in the first line or second line, they will have not doing well as the patient without receiving. And this is the difference we can see in the overall survival when patient who receive bevacizumab in the first line, or there is effect on the even the progression-free survival in these cases. And this lead the investigator to try to use this combination in the first line before using the triplet with the anti-VEGF in these patients with the BRAF mutant. And the first trial was the Encore trial, and we can see this is the patient using the triplet or the doublet in the first line, and the primary objective in this was the overall response rate. And we can see this is the demography of the patient. It is one arm study, phase 2 study. Those patients metastatic disease with the BRAF mutation B600, and we can see that the disease control rate was at 88%, which is a partial response of 47%, and the stable disease 40%, so significant rate of disease control with a response rate, overall response rate of 47%, which is a good response rate when compared to the chemotherapy in the first line. And this is, we can see the depth of the response in these patients who receive the target therapy when compared to the chemotherapy. And subgroup analysis, most of the patients, we can see from forest blood that most of the group, no significant difference between the doublet and triplet in this patient. And this is the median progression-free survival. We can see it is 5.8 months, and with the PFS, this is the significant also improvement, and same for the overall survival, it is 17.2 months, which is also significant improvement in the outcome in this patient. The side effect, as expected, you can see some of these side effect, nausea, abdominal pain, diarrhea, can happen, but the grade 3, fortunately, it is not that common with this combination. And quality of life maintained during the using different scale during treatment with this combination. So the conclusion from this study, it is a largest prospective study, and the study met the primary endpoint with the overall response rate of nearly 48%, and the median follow-up is with a median overall survival 17.2 months. So the triplet combination well tolerated, manageable, no unexpected toxicity, and this encouraged the investigator to go to randomized phase 3 trial, which is the breakwater ongoing trial now already started. It is a phase 3 trial, 3-arm using the doublet, triplet compared to the standard doublet or triplet chemotherapy with the anti-VEGF, and the primary endpoint, progression-free survival, and the key secondary endpoint, overall survival in each arm compared to the other. So, we can, if we go to the algorithm for the treatment of BRAF mutant colorectal cancer, we can see still the standard is the chemotherapy with the bevacizumab doublet or triplet and the target in second line. But we hope with the result of this breakwater will change this guideline with this target therapy become first line, and will move the anti-VEGF chemotherapy to the second line. And this are now in the NCC guideline clearly mentioned in the second line, use this combination doublet or triplet therapy in patient receiving 1 line or receive even 2 lines of chemotherapy. In the you can use this combination in the second line. This is now a standard treatment. So the take-home message: BRAF mutation V600 is rare, 8 to 10%. Poor prognosis, median survival 10 to 20 months compared to 20 to 40 months in the BRAF wild. Upfront aggressive treatment seems justifiable if the patient is fit. So FOLFIRINOX, bevacizumab is not a standard anymore, but in certain patients, if you have symptom or looking for response, you can use this combination. 4.5 allow us to select best target agent between VEGF and EGFR, and doublet bevacizumab is now the standard. In MSI, BRAF mutant immunotherapy first line is justified, and combination of target therapy are efficient in second line with high level of evidence, and the doublet encorafenib and cetuximab is the new standard. BRAF mutant patients have not to be excluded from liver met surgery whenever it is possible. Still, we have some unanswered question: what is the best sequencing? We are waiting for more data, and how to overcome the resistance when using even this triplet combination. We don't know. We need more data and more research in this field. And thank you for your attention.
Thank you, Dr. Kakil, for the excellent lecture. Do you have any questions, please, for Dr. Kakil, Dr. Fadia? Dr. Fadi?
I'm okay. It was very nice. Thank you very much. Thank you, Dr. Kakil. So I think you have the Dr. Kakil, Dr. Ari Darwish from Iraq.
Yeah.
Thank you for the nice presentation. And I join him to thank you for your nice presentation, for your nice comments. I would like to thank all the attendees. We reached up to 115, and now we are 73 almost, which is good after 2 hours and a half. I would like to thank the panelists for their participation. I would like to thank the speakers, and would like to thank our president, Dr. Sami Khatib, and Sciences Pro, the organizer for this meeting. Thank you very much. With that, we should finish, and see you next Tuesday with the GI module. And please, if you have any comment, any suggestions, please let us know. It's an open educational AMAC ASCO and UICC supported activity. Thank you very much and see you next Tuesday.
Thank you.
Just to announce, Dr. Fadi, that our next activity, our next course will be next Tuesday, 14th of September, and it will be about GU cancers.
Okay.
Thank you.
Thank you.
You
very
all.
much.
Thank you. Thank you all.
Merci à tous. Bonne soirée.
Au revoir, Dr. Tazi.
Au revoir.